Today, we'll be discussing biologic medications and their connection to type 2 inflammation. The webinar series you're listening to is sponsored by the American College of Allergy, Asthma, and Immunology, and we work together to share the latest information on advances in allergy and asthma with you. This is Sally Schessler, Director of Education for Allergy and Asthma Network. Today's webinar helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We are so pleased to welcome today's speaker, Dr. James Tracy. Dr. Tracy is a senior partner for Allergy, Asthma, and Immunology Associates, PC, in Omaha, Nebraska. If we can move to the next slide. He is a frequent speaker as well as author and reviewer of numerous scientific publications. He's a graduate of the University of Maryland, where he completed his undergraduate studies with his medical education at the University of New England College of Osteopathic Medicine. Postdoctoral efforts included a pediatric residency at David Grant United States Air Force Medical Center and Allergy and Immunology Fellowship at Wilford Hall USAF Medical Center in San Antonio, Texas. He is clinical professor of pediatrics at the University of Nebraska School of Medicine and assistant professor of medicine at Creighton University School of Medicine. He currently serves on the American College of Allergy, Asthma, and Immunology Board of Regents as treasurer. Thank you so much for being with us today, Dr. Tracy, and for walking us through this important topic.
Well, good afternoon, everybody. That was a wonderful introduction, Sally, and I truly appreciate the opportunity to share some of my experiences with this group. I'd also like to thank Tanya Winder, who's the president and CEO of the network, and of course the College of Allergy, Asthma, and Immunology for their sponsorship. This has been a really an interesting talk for me. As you'll notice, I added a little bit to the title. Initially, it was Biologic Basics, the type 2 connection. But for me, this has really been a little bit of a walk, what I call a walk down memory lane. So the more I got into this, I couldn't help but think that there's a lot of things that sort of have transpired over my career. And it really was sort of deja vu all over again. For those of you that might remember that phrase and that gentleman, that's Yogi Berra. This, as you can tell or will know, I finished my fellowship in 1993, and what we're going to talk about really is an evolution of a concept that started really about in that period of time. What we're going to do here is I'm going to give you a little bit of background and a little bit of history about the Th2, Th1, sort of why it's called that, how it sort of got to where it is, a little bit about the immunology that goes along with it. And then I'm going to use that to kind of sift through the various elements that have evolved over time that would distinguish what we often refer to as the phenotype or the endotype. So the phenotype is sort of what we see or measure. The endotype is really looking at mechanisms. So kind of slipping back, so I published a paper on cell sorting back when flow cytometry was really relatively novel. Back in 1993, the AIDS epidemic was just going crazy, and at Wilford Hall, we were right in the thick of trying to understand the immunobiology of the disease as it presented itself. For those of you that remember, back in the early 90s, AIDS was pretty much a death sentence. So a lot of what we did was trying to understand that. Now, on the immunology side, we decided that we were going to kind of take a look at what we call T cell activation. And so flow cytometry was relatively new. It was quite expensive, but we wanted to see if we could get a little bit better understanding of the mechanisms that T cells kind of engendered. It's a bit of a joke in my family that as we were doing this stuff over the years at the dinner table, I would also often talk about these things, T cells and B cells and all that stuff. And one day at dinner, we started talking. My son said, "Dad, we're not going to have another T cell lecture, are we?" And so, of course, I said, "Well, of course we're going to have another T cell lecture." So this is another T cell lecture. So if you look at this one carefully, basically we were looking at activations with immunotherapy. And it kind of is interesting because if you look at this, so this was in the abstracts for the Academy back in 1993. If you can see, mine was number 599. For those of you that are in the audience, if you take a look at the other abstract, that's 597, grass pollen immunotherapy in a 3-year follow-up. This is by a guy, it was by Walker, but Barry Kay and Steve Durham were actually published this. Now, although it has really nothing to do with our topic at hand, it is noteworthy that this is one of the primary studies that helped define the basic tenets with allergy immunotherapy of a 3 to 5 year window for treatment. And I thought it was kind of cool that I got to have equal billing with these great people. And I'm going to circle back a little bit to Barry Kay and Steve Durham because that is relevant to our topic. But let's just take a quick look over at sort of the kind of an overview. Now, this happens to be about chronic rhinosinusitis with nasal polyposis. Now, this is a graphic by Tanya Laidlaw. It was in the Annals a year or two ago, and I just think it's incredibly instructional. Now, this is about nasal polyps, but it's quite similar for the other major disease states that we deal with, which of course are atopic dermatitis, allergic, eosinophilic, asthma, obviously polyps, eosinophilic gastroenteritis, and those types of things. But so really, these are the targets for new biologics for this. Now, again, this is nasal polyps, but it holds true for the other type 2 inflammatory processes. So we've got DMP2, we've got IL-4R and IL-13, we've got IgE, we've got IL-5, we have TSLP, and all of these endotypes, which are mechanisms, will lead us into sort of what I refer to as therapeutic opportunities downstream. So it's important to understand in probably two, now obviously not the only two, but these are both gentlemen from the UK. Barry Kay has recently passed away, but Steve Durham is still with us. And I've sort of gotten, when I started doing my work with T-cell activation, it was really the work by Durham that kind of got me thinking about this, because he was publishing at the time phenotypes looking at CD4 cells that had a different sort of what we would then call the phenotype. So it's a type 1 phenotype or a type 2 phenotype. And the type 1, and we'll get to that in a moment, and then the type 2, which is basically defined by a cytokine profile that we're going to talk about in a few minutes. So the very beginning of these things really goes back to mice. And as you can see here, they're looking at two different types of helper cells with mice. And basically what they were doing is they were defining this specific lymphocyte, not so much on how it looked under the microscope, but sort of the secreted proteins and lymphokines that were being generated by it. And these later became, type 1 and of course type 2. And what those are, and we'll talk a little bit about those specifics in a minute, but this is really the beginning, and it happened obviously in mice first, but it gradually evolved. And so in the second paper, the activation of T cells increased the Th2 type, and again, work through the cytokine expression using mRNA. And as we better define these two types of, at that time, mostly lymphocytes, activated lymphocytes, I should say we now know that other cells also secrete these cytokine profiles. But back in those days, we were really thinking mostly in terms of lymphocytes. And we really began to figure out where they sort of fit, and that these really were two different types of cells. And although they may look the same under the microscope, what they were generating and how they were interacting with the inflammatory process was quite novel and quite specific. And as you can see, this is really, again, going right back into the early 90s, and this was in 1994. So let's talk a little bit about the human T cell subset. So this is kind of a busy slide, and my pointer doesn't really work. But if you take a look at this, so you see on the left with the green cell a naive CD4 T cell, and the dendritic cell is really an antigen presenting cell. And so as it kind of goes through its two top elements, you'll look at the red or pink on the top, and you can see it says Th1 cell. And as you look at that, you can sort of see how it interacts and back regulates with gamma interferon, and ultimately produces gamma interferon, IL-2, IL-10, TNF-beta, and the diseases that it's affected are really, it goes after intercellular organisms and is a pro-inflammatory mediators, and it's what we refer to as type 1 inflammation. Coming down to the next level, again, activated naive CD4 T cell is evolved through the interaction with IL-4 and IL-25 to become a Th2 cell. Combination of transcriptional events within the cell through the GAT3 protein ultimately activates STAT6, GAT3, and it spits out that cytokine profile you're seeing in the box immediately to the right of the blue lymphocyte. So it's IL-4, IL-5, IL-9, IL-10, IL-13, and IL-25. And these are relevant within the context of allergic diseases, parasitic infections, and again, the various disease states that we're going to talk about as this webinar kind of evolves. And again, the disease states really are asthma, atopic dermatitis, nasal polyposis, and again, multiple types of asthma. I'm not going to walk you through the rest of these. These are fairly self-explanatory, but not particularly relevant to this talk today. But I will say that their role in other disease states are in disease spaces is really critically important. So here we are once again with this kind of zipping through it. These are the targets. Got a little off here, so I apologize. But we'll be back to this slide again here, now that I got that fixed. So these are really the main targets. As you can see from the top, this is where the various instigators of inflammation occur. Fungi, non-specific irritants such as pollution or smoke, infections from such things as Staph aureus, bacteria, virus, and obviously allergen. And as you can see, the mix between viruses and allergens is often bridged by mast cells. That becomes relevant downstream. So the biggies we're going to talk about are going to be the anti-IL-4R, IL-13s, anti-IgEs, anti-IL-5s, and the anti-TSLPs. So what are the major properties of this CD4 subset? Well, the big players from an inflammatory role is really, number one, is under the Th1 is gamma interferon. And as you can see, there's 4, IL-4, 5, 6, and 13. And as you look to the graphic to the right, on the top bar, you have the effector cells, again, Th1, 2, Th17, and so on. And if you look along the horizontal, emanating across the very top, so we have the defining cytokines, the principal target cell, the major immune reactions, host defense, and of course its role in disease. So starting at the top, gamma interferon, its principal target cell are macrophages, and its major immunologic reaction is macrophage activation. And it's from a host defense standpoint, it goes after intercellular populations, and it's big with chronic inflammation and of course autoimmunity. Th2 is the IL-4, 5, and 13 standpoint. This actually is the target cell is the eosinophil. So it's active with eosinophil and mast cell activation, alternative macrophage activation. Its host defense is really helminths or parasites, and its role in disease is allergy. And for neutrophils, which is the next IL-17/22, neutrophil activation and recruitment, extracellular the host defenses for extracellular bacteria and fungi. And again, its role in disease is, again, autoimmunity and inflammation. So let's talk a little bit about T cell development. We won't get into a lot of this here because mainly because of time. But as we hear, you can see from the top, again, we have the epithelium and how it's induced through the activation of the naive T cell through the antigen presenting cell, the dendritic cell, which cascades into a sort of a self-modulating process through IL-4 and through the IL-4 effect from mast cells. And then through a combination of other amplifications, you can see where through STAT6 and GAT3, it ultimately brings about the full development of the Th2 type cell. Th1 is very similar. It's induced by IL-12. Its transcription factor is T beta. It produces gamma interferon and TNF alpha. Again, very much pro-inflammatory cytokines. And as in most of these mechanisms, there's a considerable amplification. In this case, it's from gamma interferon. So IL-4, 5, 6, 13, and gamma interferon. So they're the various factors. The sources are at this point mostly T cells, but there are others for each of those elements. And the critical functions. So IL-4 is critical for the IG switching to IgE. Again, decreases pro-inflammatory cytokines. It suppresses delay type hypersensitivity. Its targeted cells and targeted agents are anti-IL-4 with the alpha component, as well as IL-13. And its most active agent right now is dupilumab. Its diseases, this was sort of the disease state or scope that we talk about. So it initially became prevalent with atopic dermatitis, later asthma, and then further down with chronic sinusitis with nasal polyposis. Now there's a question mark on EoE. It's now been approved for that also. IL-5, again, it sources T cells, it increases eosinophil production. There are really three agents out there: reslizumab, Mepolizumab, and benralizumab. Again, effective with eosinophilic asthma, eosinophilic granulomatosis with polyangiitis, and again, chronic sinusitis with nasal polyposis. The MEP has been approved. The Ben is currently under, as I understand it, still awaiting approval. IL-6, lots of cells produce it. It's relevant with B and T cell proliferation and acute phase reactions. Its big diseases that we use to treat is rheumatoid arthritis and JRA. You can see the drugs that for the targeted agents, not a real big player in the allergy space, but obviously RA and JRA are really important diseases that can profoundly affect quality of life. IL-13, again, very similar to IL-4, anti-IL-4R alpha and 13. And again, dupilumab is the player here. Again, atopic dermatitis, asthma, EoE, and chronic sinusitis with nasal polyposis. The last one, which is a little different, and obviously it's a Th1 process, is gamma interferon. The big difference here, again, a product of T cells, but it affects adhesion molecules, major histocompatibility components and expression. It activates T cells, NK cells, and macrophages. There are really no targeted agents against this or specific, but it is approved for the use with chronic granulomatous disease and malignant osteopetrosis. So let's kind of move into a little bit about what we're here for, which is to say the biologics. So as you look through this, it's important to kind of understand that some of these things have been around a long time, and some have been around not so long. And the granddaddy of this whole biologic within the constructs of the allergy and asthma space is really omalizumab. It came on board in July of 2003, and at that time was approved for asthmatics at greater than 12 years of age. And one of the things as I started at the beginning is that this whole pathological mechanism of endotypes and biologics really has been the undercurrent of my entire professional career as an allergist. And I can still remember when omalizumab came on board. And as you can see, it was 11 years before there was any changes, and that was really omalizumab's indication for chronic idiopathic urticaria, now what we often refer to as chronic spontaneous urticaria. In 2015, mepolizumab was approved in November for asthmatics greater than 12. Res came in a little bit later in June of 2016. That was an interesting one because I was actually on the FDA advisory board for this particular drug. I couldn't make the MEP for various reasons, but it was really interesting as you looked at some of the primary endpoints and data points that they were using at the FDA level. And at the time, Teva had taken over this drug and was working really hard. It's still in use today. It is IV, and we'll talk a little bit about more of that in a minute. But as you can see, it's really in 2014 that things start picking up, and not just in terms of the types of biologics, but also in their various ages and indications. So in July of 2016, omalizumab gets approved with asthmatics greater than 6. That was a huge deal in our space. The big player came one of the big players came in March of 2017. That's when dupilumab was approved for eczema in individuals greater than 18 years of age. That was just a huge evolution therapeutically, because up to this point we were kind of managing atopic dermatitis with topical medications, with quite frankly only modest benefit much of the time. So dupilumab was a huge breakthrough. Ben came for asthma in March of Mepolizumab came in November of 17. Mepolizumab got its new indication for EGPA. Dupilumab got approved in October of 18 for asthma. That was a big deal. And then in early 2019, dropped the age for eczema down to 12. And as you can see, a lot of the evolution here is really indications as we move from adults to kids. But again, MEP is at 6 in 2019. Duke gets their indication for chronic sinusitis with nasal polyposis, and then it basically follows through all the way through various other opportunities. And most recently, MEP got approved for chronic nasal sinusitis with polyposis, and dupilumab got approved for asthma for greater than 6, and now it's cleared for atopic dermatitis down to 6 months of age. So everything is changing fast, and I just find this to be really an interesting profile in time. So it's been really, the other thing as we've developed these new agents is sort of the various manufacturers have gone to great lengths to kind of promote their products. And I think it's been really interesting in how they've done that. And because these are truly very novel agents, and their level of effectiveness is just, it's just life-changing, whether you have atopic dermatitis, you've got allergic asthma, you've got chronic sinusitis with nasal polyposis, and again, most recently with eosinophilic esophagitis. So let's kind of talk a little bit about what I call the granddaddy. That's omalizumab. This is the molecule to the left. Its pharmacology is that it inhibits the binding of the IgE to the high affinity IgE receptor on the surface of mast cells and basophils. There's a substantial reduction in surface-bound IgE on the high affinity IgE receptor, bringing the cell limits to a degree that in the releasability of mediators of the various allergic responses. It's indicated for moderate to severe asthma, chronic idiopathic urticaria, and relatively recently to uncontrolled nasal polyposis. And as you can see here, this is its area that it really goes after, affecting mostly basophils and mast cells. And again, very, very effective. It does have lab requirements, or at least suggestions. And it should be an IgE mediated with an IgE of greater than 30. As part of their package insert, you need to demonstrate an allergic phenotype with a positive blood or skin test to a perennial allergen. In the case of chronic idiopathic urticaria, you need 6 weeks of uncontrolled hives with high-dose antihistamines. With nasal polyps, there's really no lab requirements for prescribing. Most insurance carriers require an inadequate response to intranasal corticosteroids. Right now, it's indications from an age standpoint, greater than 6 for asthma, 12 or more for chronic idiopathic urticaria, and greater than 18 for nasal polyposis. Which brings us to dupilumab. Again, a fascinating disease. And the graphic to your right is just how it is. The individuals who go on this medication, it is just absolutely amazing. I've had some patients that have told me that they could feel a drop in itching within hours after their first injection. And as we know with atopic dermatitis, it's not so much the rash that itches, it's the itch that rashes. It's really the mechanics of scratching that generates the rash. So if you interrupt the itching cycle through whatever means, you can have a very immediate effect on the outcome from a symptomatic standpoint. So its pharmacology is it's really a monoclonal antibody that targets the IL-4 receptor alpha subunit and blocks the intercell signaling of IL-4 and IL-13. Its indications: moderate to severe uncontrolled atopic dermatitis, moderate to severe uncontrolled eosinophilic or oral corticosteroid dependent asthma, and then again, more relatively recently, is uncontrolled chronic rhinosinusitis with nasal polyposis. And this is where it kind of sits. Remember, this cascade kind of falls down. At the top, you got TSLP and the mast cells, and then the adaptive Th2 response, and then the innate Th2 response, and the IL-4/13 is at that point. Again, the lab suggestions, atopic dermatitis, really no lab suggestions before prescribing. However, there are almost always clinical, depending on the carrier, about relative percentages of body surface area. With asthma, no specific range for eosinophilic, but there is evidence that efficacy exists with eosinophilic, that better efficacy exists for eosinophil counts greater than 150. Again, as with omalizumab, there's really no lab requirements for chronic rhinosinusitis with nasal polyposis. Ages down to 6 months for atopic dermatitis, which is just absolutely amazing. 12 or higher for asthma, 18 or more for chronic sinusitis with nasal polyposis. Kind of slipping down the cascade here to IL-5, and if you remember, it sort of parallels at that similar level with to IL-4. But in the case of the anti-IL-5s, we're really looking at 3 different drugs, or 3 different monoclonals, which, although these certainly have similar effects, how they're dosed is different, and some of their endpoints are a little bit different. And again, as I mentioned before, it sort of sits right next to IL-4 in the innate type 2 inflammation position. So mepolizumab, obviously an injection. It's humanized monoclonal antibody that binds to IL-5, inhibiting the bioactivity of the IL-5 by blocking its binding to the alpha chain of the IL-5 receptor complex, which is, of course, expressed on the surface of eosinophils. Its indications, though it certainly is add-on therapy for patients with severe asthma, but again, you have to have an eosinophilic phenotype. It's been approved for eosinophilic granulomatosis with polyangiitis, or EGPA, again, only for adults, and also for hypereosinophilic syndrome, or for those greater than 6 months without an identifiable non-hematologic secondary cause. Again, injection. Lab requirements, least suggestions. Consider herpes zoster vaccination if medically appropriate before you start. You need EOs greater than 150 within the last 6 weeks, or 300 within the past 12 months. Age requirements: greater than 6 for asthma, greater than 18 for EGPA, greater than 12 for HES. And reslizumab. Again, very similar in its pharmacology. It binds to the IL-5, inhibiting the bioactivity of IL-5 by blocking binding to the alpha chain of the IL-5 receptor complex on eosinophils. Again, its indication is for severe asthma with an eosinophilic, that's actually phenotype, not phenotype. Its lab suggestions are EOs greater than 400, age greater than 18, and it's dosed, interestingly, which is noteworthy here, is that it's dosed based on weight, which is unusual because most of the other ones are single dose opportunities based more on age than actual weight. It is an IV infusion versus a sub-Q or IM process. Benralizumab, again similar. It binds to the alpha subunit of the IL-5 receptor on eosinophils, blocking the action of IL-5 and inducing apoptosis in eosinophils through the interaction with NK cells by antibody-dependent cell-mediated cytotoxicity. Again, its indication is for severe asthma with the eosinophilic phenotype. So although there are some similarities there are some differences. There's no doubt that Ben basically is a knockout for eosinophils. It really does take the eosinophil count from really wherever it was to effectively 0. Lab suggestion, no specific range for eosinophil counts, but evidence of efficacy, superior efficacy exists for eosinophil counts greater than 150. It's for those individuals 12 and older. And again, it's dosed 30 milligrams every 4 weeks, and then ultimately can be spaced out to every 8 weeks. Tezzy here, gotta love their marketing. Again, it's a human monoclonal antibody that blocks thymic stromal lymphopoietin, TSLP, and thus inhibits TSLP signaling through the TSLP receptor complex. Its indication is really add-on maintenance for severe uncontrolled asthma with really no specific phenotype or biomarker limitations. It's noted within the insert that it's not indicated for the relief of acute bronchospasm or status asthmaticus, even though it's pretty high on the chain. And it kind of lives up here. Again, I always kind of think of this as kind of downstream. So TSLP or anti-TSLP lives at the top of the cascade. I'm not sure that analogy is completely true, but this is sort of how I mentally visualize it. Again, it's pharmacology. It's a human monoclonal antibody that binds thymic stromal lymphopoietin, thus inhibiting TSLP signaling through TSLP receptor complex and getting its add-on for severe uncontrolled asthma. And again, it lives up here. Lab suggestions, really none. Ages are 12 and older. The dose for asthma is 210 milligrams administered subcutaneously every 4 weeks. This does have to be administered in a clinician's office, but you can see what TSLP really affects all CD4 cells with T cell differentiation, basophils, dendritic cells, mast cells, and natural killer type. And again, we talked about those pro-inflammatory viruses or inflammatory cytokines or proteases or bacterial products. And here this is really a nice graphic. This was published in June of this year. It's in the Journal of Allergy and Clinical Immunology and Practice. I'll circle back to that in a few minutes. But really, this gives you kind of a nice little overview. Now, much of the previous cartoons were really centered around nasal polyps. This is definitely about asthma. But as you can see, it gives you kind of a nice picture of sort of the biomarkers that are involved. So it's blood eosinophil count at whatever level they are. So if you come to the far left, if you have blood eos of greater than 300 and a pheno greater than or equal to 25, the anti-IL-4 receptor antagonist, dupilumab, or one of the anti-IL-5 would be indicated. Anti-TSLP would be indicated for that. If you got peripheral eos greater than 1,000 and a pheno greater than 25, the anti-IL-5s would work. If you have eosinophil counts less than 300, but a pheno greater than 25, the anti-IL-4 receptor antagonist or TSLP would be indicated. So this would be, I should mention here that one of the challenges that we face clinically is that a lot of these individuals that we see with severe asthma have been on generous doses of oral corticosteroids, which inherently suppresses the peripheral eosinophil count, making sometimes the diagnosis a little bit challenging for the clinician. But again, keep moving to the right. So we've got eosinophils greater than 300 with a pheno less than 25. So whether it's, even in this case, the anti-IL-5s are very, very much indicated as first-line therapy. EOs less than 300, but a pheno with a pheno that's also less than 25, anti-TSLP would be the way to go. And as you can, when you look at sort of the second line, you would consider the TSLP or the anti-IL-4 receptor antagonist in the same place where the blood EOs are exceptionally high, really regardless of where the phenos live. So as we kind of approach the end of our talk and open things up for questions, there's just a few things I sort of wanted to sort of kind of touch on. The first is really this picture. This is the cover of the Journal of Allergy and Immunology, Clinical Immunology and Practice. This is really a marvelous journal volume. Its theme really is chronic rhinosinusitis, but as you've seen from my talk, there's an awful lot of overlap between the various allergic disease states as it relates to the biologics and the various utility amongst the biologics. And there's definite overlap. But this volume really does a nice job at working through many of the clinical pieces, indications, and then a couple of the controversies that really are often looked at. You know, there's a couple things that you always have to ask the question is, so one of the differences with the manufacturer, AZ sort of AstraZeneca uses the fact that basically we're knocking out the eosinophils to zero. And one of the questions is, you know, that I've often raised myself. He said, does that have a downstream effect that we don't know about? I mean, I always tell folks, I said, well, God put those EOs in there for a reason. And if you bring it down to zero, is that going to have an adverse effect? Well, it's interesting. So that was kind of addressed in this journal article, in one of the journal articles by Kristen Lieberman and Jerry Gleit, and really looked at in a constructive way, is there relevance here? And it's, although the disease states may vary, it may not be. It might be okay. I'll just refer you to that specific article. The other really is really, how long do you treat these people? Is this something that's for the rest of their life? Is it something that's going to have to be looked at? I mean, is there an endpoint? We know that a lot of these diseases, depending on the age, are lifelong. Does that mean they need to be on a biologic? This is definitely an unanswered question that only time will tell. The other thing is really cost effectiveness. So again, there's several works that have been in place, both in the European literature, and it's addressed here from an economic standpoint. And we really don't have time to go into it, but there's an article here on the biological comparison of the biological effects with the various biologics compared with endoscopic sinus surgery, but looking at it not from a disease management standpoint and disease burden standpoint, but mostly looking at it from an economic standpoint, where we look at the cost of these therapies, which is considerable in proportion to what are the various opportunities. And there's an article by Rick in this journal volume that kind of looks at that in a very productive and important way. So these are really sort of important elements. And so, kind of just a couple of quick thoughts. I am just completely amazed over the course of my career and how our understanding of the biology of inflammation has led us to understand sort of the mechanistic elements of the various disease states, which of course has lend itself to understanding therapeutic, what I refer to as therapeutic opportunities. And there's no doubt that there'll be more. And really, I touched on just a few of them. There are many other biologics that are currently in development, and I think that and they're not just again Th2 types, but as we move through our practice careers, this is definitely the future. Immunology and how it affects life at the cellular level has been critically important and will continue to be critically important. I just find it really, for myself, interesting. This really started at the beginning of my career, and as I come towards the end over the next few years, you have to ask yourself, kind of what's next. My personal feeling is that it's going to be some of the technology that we've seen with the recent COVID epidemic and the mRNA vaccinations. The whole biology of gene modification through the CRISPR techniques that have been implemented, and which we've actually operationalized at many levels, is really kind of, I think, the next step in the future. And I think it's just intriguing that the longer we're here, the more we learn, as indeed it should. So with that, Sally, I think it's time to open it up for questions if you'd like.
Oh, thank you so much, Dr. Tracy. Totally appreciate all your thoughts on this. We do have some questions. Our first one is, do biologic medications lose their effectiveness over time? Can you switch biologic medications?
That's kind of a debated topic. The answer to the second question is easy. But first of all, they don't work with everybody. And so there's definitely room to move things around if your clinical response isn't what you thought it would be. An excellent example was when Omaha came on board. We realized that, and I can say in my practice, I mean, I had hundreds and hundreds of patients on this stuff, but it clearly worked better for some people than it did for other people. And for individuals where it works good, they kept going on it. But as new biologics evolved, particularly the IL-4 and IL-5 products, we switched them. And for whatever reason, their phenotype was more responsive once you work through the endotype. So in their case, going after the eosinophil instead of the anti-Ig may be the way to go. It's also noteworthy, the similar observation kind of came with nasal polyposis. Those of us that have been doing this for a while, we realized that although we were treating them for asthma, we noticed that in some of these patients, their polyps got better. And that's kind of led us ultimately to a deeper understanding of this disease product. So the short answer is, my personal feeling, they don't necessarily lose effectiveness, but they may not be necessarily effective with everybody all of the time. And moving them around probably has a place.
Thank you. Our next question comes from a patient. She says, I started receiving Omalizumab every 4 weeks back in April when I was diagnosed with eosinophilic asthma. I've been a lifelong asthmatic. I'm in my late 50s. Do you know how long it will take to take effect? I still have to use my rescue inhaler about once weekly, especially before going to bed, and I'm still taking my controller medication daily. The main symptom I have had for the last 2 years is a chronic cough. No COVID-19 infection ever. Thank you for answering my question.
Well, before I move somebody to a different biologic, I usually wait at least 4 to 6 months. I didn't pick up exactly how long it had been since she started. Can you repeat that part, Sally?
She said she was diagnosed in April. She was given the med in April.
So if she started in May, you know, I'd give it, this is what I usually do. Now, there are differences of opinion here, but I usually wait 6 months before I make a switch. And then what I would do is then I would probably see if she fits into one of the other phenotypes.
Okay, our next question is, what do you recommend that we tell patients when they ask how long they will be on the biologic?
If I could answer that one, I'd win the Nobel Prize. The short answer is I don't know. We don't know. For a lot of these agents, it would just, again, looking at the TSLP model, we don't know exactly if you disrupt the TSLP at the highest level of the inflammatory cascade, is that going to have a longevity effect? We don't know. Mostly what I tell folks right now is it's indeterminate, but it is possible it could be for the rest of your life. But at this point, we just don't know. What we do know is that we have patients on Omalizumab since 2003. I'm sorry, is it 3? I guess 13, and they're still on them. But we also know that some people, for whatever reason, have come off of them, and they seem to be doing reasonably well. So we really don't know the answer. I usually tell folks that we don't know yet, but it's possible it could be for life. It could be for life.
Okay, our next question is, what's a biosimilar? I've heard of those. And how do I know if I'm getting a biologic medication or a biosimilar?
Yeah, so basically a biosimilar is a generic form. And so in our disease state here, there really are no biosimilars yet. The first one that'll come out would probably be Omalizumab. There are biosimilars in other disease spaces, which, you know, to be honest, like the TNF alphas, there's several that are out there. And the answer to your question is you just have to ask. Unfortunately, a lot of those choices are driven by carriers and insurance. And the other, just again, in full disclosure, so you have to be within, I think it's 10 to 15% for generic drugs. I don't know what the FDA parameters are for biosimilars off the top of my head, but I'm guessing there's something similar.
Okay. Our next patient question is, I started Omalizumab in clinical trials. It is a life changer. When will the black box label be removed? I need more freedom to live my life outside of the doctor's office.
That's a great question. Short answer is, I don't know that it'll ever be completely lifted. What I can tell you though, in the post hoc analysis that they've done, the reason the black box is, well, there's a couple issues. One is tumors, and I'm not sure why that is, and the other one is anaphylaxis. So the anaphylaxis one, you know, I'm not sure exactly where Genentech and Novartis are with that, and you know, it's really hard to get a black box removed. I personally, what I tell patients is through reassurance that if you're looking at the anaphylaxis piece, again, it's been a long time since I looked at the package insert for Omalizumab. It's been out so long. I just really don't worry about anaphylaxis anymore. And if somebody asks it, because you know we have the questioner here is obviously very sophisticated, and so you know when you read this stuff, black box warnings are there out of an abundance of caution, and the dynamics that drive it are quite variable. and some of them are science-based and some are a little more emotionally based. In this case, for anaphylaxis, I mean, we give tens of thousands of doses of this stuff, and I don't know that I've ever seen a real anaphylaxis. Now, I definitely have heard about them, and I know my partners have, but I myself haven't. With regard to tumors, and perhaps that was the other element. So in the original studies, they didn't exclude solid tumors, and so that got put as an AE. In the post hoc analysis, when they re-examined the stuff where they excluded those individuals, there does not appear to be any risk of malignancy associated with omalizumab. And if it's been as big of a disease changer, then I just keep doing it.
Okay. Our next question is, what about biologics and treatment with patients that have COPD with asthma overlap?
You have to meet the various criteria for this. So if their asthma is been long-standing, but it's eosinophilically driven, and you meet the various parameters in terms of either pheno or anpheno and totally eosinophils, I would think that would still be an effective therapy. Some of the newer agents like Tezi, that we don't know yet. It's relatively new, and I'm not sure they've gone for that indication. It's a little different disease state, and you may not get quite the level of effectiveness as you would if you had a pure asthma state, just because of the nature of the disease. But I would think that it should be helpful, at least in a certain percentage of patients.
Okay, we have two more questions. Our next one is, how can pheno testing better steer treatment selection?
So the whole idea of pheno is its utility and ease of, and accessibility for recognizing an eosinophilic driven airway process. The reality is you can have an eosinophilic driven process and still have a normal pheno. I think there is great difference of opinion on how much weight that decision becomes into it. It's definitely easy. It's definitely relatively inexpensive to do, although it's often not reimbursed. Again, because of its variability in it and its utility. I'm speaking only for myself. I kind of stopped using pheno unless I really I use it more as a gauge for compliance, quite frankly, than a therapeutic driver, just because I find it so variable and erratic. Some of my most severe, and I know eosinophilically driven asthma, have phenos of like 5 or 2 or less. So I just don't know if it's low. It just doesn't make that much. It doesn't change my perspective. The other markers are much, in my opinion anyway, are much more reliable.
Okay, thank you. Our last question is, do you think there will be more biologics available that can be safely administered at home?
Yeah, I don't know when. I mean, there's several out there right now that are under development, and so yeah, this is definitely a growing industry and an evolving therapeutic window here. I don't know when off the top of my head. We're still kind of dealing with a lot of stuff from COVID and from a pulmonary standpoint, and but I think that I don't have any doubt that this is going to continue as we move through our practice lifetimes. But yeah, I'm sure there will be. So, and again, I'm just kind of circling back to that question in the journal article titled page that I have up on the screen right now. They actually talk about that, and all the various things are sort of in the pipeline, and the disease states that they might be applicable to. So yeah, I think that there will be. As far as home use, that's going to be that's often a regulatory type of thing. So the short answer is I'm sure they are. I don't know when that will happen, and even if they are approved, when they get approved for home use is going to be different. Some things are can get through pretty quick. Some things, not so quick. And so, yeah.
Well, thank you so much, Dr. Tracy. You've not only talked about what there is to look at now, but we even made you get out your crystal ball a little bit and take a little look at the future. But we really appreciate your time and energy and expertise today. And I'd also like to thank our listeners for joining us today. At this time, please download the certificate attendance from your control panel. If you have any difficulties, please email us using the link in your emails. If we could go to the next slide, please join us for our next Advances in Allergy and Asthma webinar as we discuss current and future treatments for food allergy. This webinar will be on September 27th at 4:00 p.m. Eastern Time. You can register for this webinar on our website at allergyasthmanetwork.org. Scroll to the bottom of our homepage to webinars. You can also view our recorded webinars on this page on our website. And if you can go one more slide for me, please visit our website for quality guidelines resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us today. Please stay online for 2 to 3 minutes to complete the evaluation survey. This is Sally Schessler for the staff at Allergy and Asthma Network. Thank you for looking at biologic medications with us today, and we look forward to having you join us next time on Advances in Allergy and Asthma.